In this section, we're going to start off with the condition called cor pulmonale, and you may recall that in our previous course we discussed this. And I want you to know that cor pulmonale is going to have a proper definition, and the definition of cor pulmonale is going to be specifically right ventricular hypertrophy with dilation on the right side of the heart. And the major cause of this is going to be pulmonary hypertension. So there are going to be several different factors which go into the production of cor pulmonale as compared to those which normally affect the left side of the heart. Now, last trimester we talked about acute cor pulmonale, and we had said that the most common cause is going to be a very large pulmonary embolus. So these guys tend to develop from a deep vein thrombosis. So I want you to imagine for a moment that a very, very large thrombus originates from a deep leg vein, travels through the inferior vena cava, travels to the right side of the heart, and so we're going to draw our heart right here, and then recall that our pulmonary trunk, which is right here, is going to divide into a left and a right pulmonary artery. I want you to now imagine that this very large deep vein thrombosis, which is embolized, then saddles up and begins to block the blood flow, which is going to go to each lung, right here and right here. As a result, there is a massive pressure buildup in this particular region right here of the pulmonary trunk, thereby satisfying the conditions for an acute version of cor pulmonale. And so when we talk about cor pulmonale, we're talking about a right-sided heart failure. The acute version doesn't really give you enough time to produce right ventricular hypertrophy and dilation, but rather you have this massive blood which is going to exhibit back pressure to the right side of the heart, and so the right side of the heart will appear dilated. In the next case, if we look at chronic cor pulmonale, what I want you to realize with chronic cor pulmonale is that it is going to be most associated with chronic obstructive pulmonary disease, COPD. And so there are a number of conditions that we're going to talk about in our next section which will make up the syndrome of COPD. But the two that I want you to know about is going to be chronic bronchitis and emphysema. And there's a mechanism which is going to explain this and allow me to do so. If we simplify the lungs for a moment and show that your trachea and your airways are going to be shown by this particular tube right here, and let's just say that an alveolus is right here. Recall that when we breathe in and out, we will be bringing air in and bringing air out. Hopefully that air is going to have sufficient amounts of oxygen, and the reason why we want that sufficient amount of oxygen in the alveolus is because we have these pulmonary blood vessels which are going to be skirting the outside of the alveolus as such. Now, if we have an obstructive pulmonary disease, and we're just going to show that as some type of obstruction which is limiting airflow to the alveolus, and I'm showing that as this little lesion right here, what ends up occurring is that oxygen levels go down inside of the alveolus. Now, the general compensation for that in this case would be vasoconstriction of these blood vessels. So rather than having a very large patent blood vessel as you're being shown right here, what you would expect is, okay, there's the airway, there's the alveolus, and then what I'm going to do is I'm going to show you a very, very thin blood vessel. And that's just a normal physiologic compensation to a block in an airway in the lung. The reason why we have this compensation is to divert good blood to other alveoli. But when an individual has COPD, what alveoli are affected? Well, all of them are affected. So imagine what would happen if the entire lung is behaving this way, where all of the pulmonary tiny little vessels are vasoconstricting. Obviously, this would be creating a massive back pressure into the pulmonary trunk. And as a result, what we would do is we would be able to satisfy the definition of cor pulmonale. So with increased hypertension to the pulmonary artery, you are going to have that pressure overload to the right side of the heart. Now, we also state that there's going to be a volume overload to the right side of the heart. And here's the reason why. If this is the pulmonary trunk and here is the pulmonary valve, which is coming off of the heart, we have a nice little set of semilunar cusps, and let's just say that here is going to be the right ventricle. If I massively dilate the pulmonary trunk here and here, I'll actually start to spread these semilunar cusps away from one another, which will allow a certain degree of regurgitation of blood back into the right ventricle. As a result, not only am I going to have to work against the pressure to the right ventricle, now I have this volume of blood which is then going to enter into the right ventricle, causing both an eccentric and a concentric hypertrophy at the same time. This will be demonstrable when we actually look at a transverse section through the heart. Now, normally, as we've drawn in pictures before, if we showed the left ventricle, let me go back here for a moment. If we showed the left ventricle, we would show the left ventricle like this, with the chamber being nice and concentric, and the right ventricle would be like this as a crescent. And notice what has happened here. In fact, what has happened here is that the right ventricle has hypertrophied so massively that we have the right ventricle being concentric and the left ventricle being more crescenteric. So we see this massive right ventricular hypertrophy. What you'll also see on a radiograph is when you look at the heart shadow, and the heart shadow should normally be kind of like this. Not a lot of the right ventricle should be on the right-hand side of the radiograph, but when you have chronic cor pulmonale, you'll start to see the right ventricular shadow encroaching upon the right lung field. In this section now, I want to introduce a brand new topic, and this is going to be rheumatic heart fever. And rheumatic heart fever is a consequence, and it's a consequence to a group A beta hemolytic strep infection. So this is an individual who at a certain time in their life acquired a strep pyogenes infection, which then goes systemic, and as a result they have a systemic inflammatory reaction. You'll notice that we're including a bunch of different organs here: the heart, the joints, and the central nervous system. We're going to concentrate on the heart, and the key factor in this particular type of disease is going to be the notion of what is called molecular mimicry. There's something about a strep infection which is going to turn on the immune system and then create antibodies that will be directed towards self. And so the body gets tricked into thinking that elements of their heart are actually going to be foreign antigens. And so what I want you to notice here for a moment is in this particular diagram that an individual is going to be infected with strep. The strep will go systemically. And with regards to strep pyogenes, what will happen is that there is a specific protein on strep which is called the streptococcal M protein. And these streptococcal M proteins will cause the generation of these anti-streptococcal antibodies. The problem here is that when we develop those anti-streptococcal M protein antibodies, those antibodies can cross-react with elements of one's own heart. And so what we have here is we can start to attack the myocardium, we can start to attack the pericardium, we can start to attack the actual valves. And so rheumatic fever, therefore, becomes this instance where we have attack of the various different layers of the heart, and what we're going to do is we are going to try to describe them. So one of the first things that I want you to know here is that we can look at rheumatic heart disease as being an acute presentation and then a chronic presentation. And in acute presentations of rheumatic heart disease, we will see pancarditis. So let us make sure that we understand what pancarditis is. All three layers of the heart are going to be affected, which means the individual presents with pericarditis, they are going to present with myocarditis, and they are going to also present with endocarditis. So let us talk about the presentation of each one of these. Let's start off with myocarditis. Imagine, if you will, in an acute presentation where we have myocarditis, the thickness of the myocardium actually increases because as we generate these antibodies against the myocardium, recall from last trimester, white blood cells are going to show up to the scene. And so the thickness of the heart muscle itself is going to be dilated. And we will have characteristic left characteristic myocardial inflammation, which is going to be a granuloma in character. And these characteristic findings are going to be found in this particular slide right here. So imagine, if you will, you are looking at, and I'm outlining it right here, this entire slide right here. This is supposed to be in the wall of the myocardium, and what you're looking at here are going to be the characteristic findings of a granuloma in the heart subsequent due to acute rheumatic fever. That's called an Askoff body. So an Askoff body is the granuloma which is found in acute rheumatic fever. The characteristic cell of this Askoff body is going to be called an Anichkow cell. And a Anichkow cell has a very characteristic appearance to it. We say that the nuclei has a caterpillar appearance. So if you hear any mention of Askoff bodies and Anichkow cells, what we are talking about are the granulomas that are characteristic to a rheumatic fever. And notice how we are concentrating here on the myocardium. We can actually see some myocardial cells right here. We can see some in the periphery right here and right here as well. If we go to the next slide, again with an acute presentation of rheumatic heart disease, you will also attack the pericardium. And this is where it can become clinically really evident. Individuals who suffer from pericarditis are going to have an acute presentation of pain. They're going to feel as though they're having a heart attack. And recall the type of pericarditis that we've talked about in previous classes. This is called a fibrinous pericarditis. The antibody-mediated attack of the pericardium is going to result in the release of fibrin. That fibrin begins to polymerize between the layers of the pericardium, leading to the production of this buttery-like exudate. And so we call that a bread and butter pericarditis. When the pericardium begins to stick onto itself, what happens that every time the heart beats, the pericardium makes this rubbing sound, and as a result, oscillatory findings present as a friction rub. Again, another one of those buzzwords that we should be aware of here. In the case of an endocarditis, this is where we can start to look at some of the long-term effects that occur with regards to the heart. Again, we have this antibody-mediated attack of the endocardium. The valve leaflets are going to become inflamed and they become edematous. But if we look and compare the left side versus the right side of the heart, we tend to see that the left side of the heart becomes more injured because they have to open and close under greater pressures because, of course, the left ventricle is going to contract more forcefully. As a result, this set of valves, and I'm kind of trying to show you the mitral valve here. And again, remember they're going to open by swinging this way, and then they close by snapping shut. When they snap shut, this region where the two valves are going to touch becomes inflamed, edematous, and it begins to express adhesion molecules, and as a result has a greater likelihood for fibrin and platelets to begin to deposit on its surface. These little nodules of fibrin and platelets are going to produce these things that are called verrucae along the leaflets, and that's going to be shown in a subsequent slide. If this occurs over a long period of time, we're actually going into something which is going to be called chronic rheumatic fever. The myocarditis and the pericarditis tend to heal without any type of complication. The issue here is going to be that the endocarditis can lead to chronic complications. So of the three layers of the heart, it is the endocardium which is most prone to chronic degradation. And what I want you to start thinking about is that those lesions that we started talking about at, let's say, the mitral and the aortic valves, because they are the ones that are going to be operating at greater pressures, they are going to have this chronic change that begins to occur where these valves begin to snap shut. And so I'm showing you the mitral valve right here. I want you to think about this continued deposition of fibrin, of platelets, and remember, these tiny little thrombi can begin to become organized, and so we can have the deposition of scar tissue as well. And so that's what I'm trying to demonstrate right here. As a result, we'll have a valvular dysfunction. Perhaps these valves will become more rigid. Perhaps they can become stenotic as well. Perhaps they might not even close properly. So not only might they become stenotic, they may also demonstrate the ability to become regurgitant. And so that's what we're demonstrating in these particular points right here. Again, an individual is going to have these changes over a long period of time. How do we diagnose this in our patient population? Well, again, a couple of buzzwords here. We have this thing that is called Jones criteria. And Jones criteria is going to be those set of factors which leads us to believe that the individual may have rheumatic heart disease. And so we look at whether or not certain criteria are met. What I'm showing you on this slide are the major criteria. If an individual presents with two major criteria, either being a history of carditis, which means that they might have murmurs, on radiographs they have cardiomegaly, pericarditis. Recall that pericarditis may be evidenced by the fact that they have a pericardial friction rub, or if they have evidence of congestive heart failure. These will be major criteria for carditis. In terms of joints, if an individual presents with multi-joint inflammation that is not going to be explained by osteoarthritis or rheumatoid arthritis, so a person has this polyarthritis, if they have a presentation of a dance-like movement, and so there are forms of choreas which will occur, which are these grossly visible writhing movements that the patient is going to present with, and these subcutaneous nodules as well as a redness to the skin. If an individual presents with any two of these particular factors, we can come up with a positive diagnosis of rheumatic heart disease. Or if they only have one of these major criteria and then two minor criteria, we can also come up with a diagnosis of rheumatic heart disease. And notice that the minor criteria would be a previous history of rheumatic fever, so an individual who had a systemic strep infection, again, fever along with joint pain. And then we have these guys right here, an increased ESR. ESR means erythrocyte sedimentation rate. It is a non-specific indicator of inflammation, right? So a wide variety of conditions can give an increased ESR. When an individual undergoes inflammation, what we tend to see is that their red blood cells kind of fall out of solution or suspension a lot quicker because the red blood cells begin to stack up on one another and they form these things which are called rouleaus, or these little rolls, and they just fall out of solution. C-reactive protein is going to be a substance which is also going to increase in regards to inflammation. And once again, it's a non-specific indicator of inflammation. A wide variety of inflammatory conditions will cause an increase in C-reactive protein. The nuts and bolts here of a chronic rheumatic heart disease is going to be that there are going to be valves that will be affected in order of incidence. So probably the most important information on this slide is going to be right here. In terms of the complications of rheumatic heart disease, in order of incidence, it is the mitral valve that is first going to be affected, followed by the aortic valve. So it's the most commonly and most severely affected one. The information that we're showing you here prior on the slide is that there are some complications in terms of rheumatic heart disease in which an individual can develop bacterial endocarditis. The reason being is that when we start to affect valves, whenever we produce inflammation on a heart valve, we make the valves sticky. And when you make a valve sticky, right, again, we're going to show you a valve right here, and we're going to show you a valve right here, and we've activated the inflammatory system along the margin of the valves. What will happen is that this is now going to be an ample focus for things to stick. And so if I stick little pieces of fibrin in here, these guys can break off. And now you have a thromboembolus. So these tiny little varicae that are produced, when they are dislodged, there's the susceptibility for embolism with distal arrest in a capillary or a blood vessel. You'll notice that individuals who have prior history of heart disease and valvular change often are going to have to take precautionary measures when they go to the dentist. This is going to be even more apparent when we start talking about conditions like mitral valve prolapse. One of the things that is going to occur as a result of this chronic rheumatic heart disease is mitral stenosis. So when we talk about changes at the level of the heart valves, mitral stenosis is one of those changes which we will see in a chronic rheumatic heart disease. What ends up occurring is that the valves start to stiffen up, and so we start to lay down this fibrous connective tissue along the valves. We start to lay fibrous connective tissue on those chordae tendineae. Even we start to produce a more rigid papillary muscle. We start to build inwards as well, and so this chronic inflammatory process starts to close the caliber caliber of the diameter of the mitral valve itself. And it gives a characteristic look when we look at it from a ventricular view. We have a fish mouth looking valve. And so we have that on this particular slide. Notice how this part is being viewed from the inferior, from the ventricular aspect, and some individuals say that it looks like the mouth of a fish, sometimes even like a catfish, where here are the whiskers or whatnot. I want you to understand that both stenosis and regurgitation is going to occur with regards to the consequences of chronic rheumatic heart disease. Stenosis is going to occur because, well, we are dumping in all of this fibrous connective tissue, but they're also going to be regurgitant because the valve cannot close properly. As a result, each time that the heart is going to contract, a jet of blood is going to exit from the ventricle back into the atrium. And as a result, we can also have further damage of the atrial endocardium. This is going to contribute to an overall inefficiency of the heart. Remember, if this blood is regurgitating back into the left atrium, you can sometimes even have a dilation of the left atrium. It means that blood is not going to be leaving the heart. And as a result, the individual is going to get tired really fast, so they're going to have dyspnea on exertion. Now, an interesting thing here as well is that if the heart begins to dilate, specifically the left atrium, so we're going to have a little picture of the heart here like this. There's the heart. Recall that there's a ventricle right there. There's a ventricle right there. Here's an atrium. There's an atrium. Now I want you to imagine the left atrium dilating massively here. So recall some of the structures that are going to be here if the left atrium begins to dilate. First of all, you have the aorta, which will be found here. You'll have the pulmonary trunk, which will be found here as well. And recall from Gross 1, you also are going to have that left recurrent laryngeal nerve, which is supposed to loop underneath. So an individual with this mitral stenosis can sometimes develop hoarseness of the voice because the left atrium is going to begin to occlude that area between the aorta and the pulmonary trunk and pulmonary artery, and thereby compress the left recurrent laryngeal nerve, leading to a change in the characteristic of the individual's voice. Also, I want you to start thinking about backwards complications. Remember, if blood is not making its way through to the systemic circulation, it's going to back up into the pulmonary circulation. As a result, there's a small degree of pulmonary hypertension that may occur. And so this individual has a persistent cough. We are compressing the bronchi because of this massive dilation, and some of the delicate blood vessels in the individual's alveolar capillary network may begin to burst, and as a result, they're going to have the sign of hemoptysis. They're going to cough up a little bit of blood. Individuals with mitral valve stenosis also tend to have what is called the mitral facies. The individuals tend to have these chronically pink-purple patches on the cheeks. And so that is one of the outward signs of an individual with a mitral valve stenosis. As a general feature that goes along with mitral valve pathologies, we can also talk about mitral valve prolapse. Mitral valve prolapse is a slightly different discussion. Recall each time that we've been drawing the mitral valves, what we've been doing is we've been showing these inwardly directed valves as such that are tethered to those chordae tendineae, and from those chordae tendineae we have those papillary muscles as such. In the mitral valve prolapse, the valve improperly closes, and if we go to this side of the screen, when the valve closes, what can sometimes happen is that one of the cusps billows out. And as you can appreciate, well, this is going to allow the regurgitation of blood through the mitral valve back into the left atrium. And so we will have signs of this when an individual has a Doppler ultrasound. You're going to notice that it is the most common cause of mitral regurgitation. And so let us take a look at it here in this transverse image. This is the mitral valve right here that we're discussing. Now, the general contour of your atrioventricular valve should almost have this kind of corrugated appearance to them. So you notice how it kind of looks gnarled and almost craggy? Notice in this side, the mitral valves almost have this pillow-like or a billowing type of appearance. That's because they're projecting into the atria. We've removed the atria in this gross specimen. And so this is the general gross anatomical look. If we suggested that a patient goes and sees or has an ultrasonography done, we would be able to see jets of blood emanating from the left ventricle going into the atrium, thereby evidencing the fact that they have a mitral valve prolapse. And most commonly, this is going to be due to unknown etiological factors. It's a familial distribution, and so individuals just simply present with it. It is thought that it might be related to a papillary muscle dysfunction. Perhaps they're not contracting at the right time, or we just don't know. You'll also notice that it can be inherited in those particular diseases where there is a lot of compliance of tissue, so Marfan's and Ehlers-Danlos syndrome, or even those ones where we have inappropriate collagen production, where we have very stretchy materials. Again, they're compliant, but they're not elastic. The clinical features, well, it depends on the patient. In many cases, it's going to be asymptomatic. The individual just simply doesn't know that they have it. It can also lead to palpitations, and in palpitations, it just means the individual is going to become consciously aware of their heartbeat. It doesn't necessarily have to be something where they are continuously in this prolapse situation. In fact, the prolapse can spontaneously reverse itself. When they get these palpitations, they'll actually hear a clicking sound in their chest. And so we call that clicking sound a systolic click, and it's important to notice that. It's a systolic click. What a systolic click is a clicking sound that is going to be found somewhere between S1 and S2. So that click is going to happen somewhere around here. Remember that S1 is going to be the AV valves closing, and S2 it's the aortic and pulmonary valves closing. When you have a mid-systolic click, what happens is that the AV valves close, and then what will happen is that here at this mid-systolic click, the prolapse occurs where one of the leaflets kind of snaps across the other, creating that clicking sound. So this is a unique sound to your mitral valve prolapse. Now, that click can also cause physical damage to the endocardium. So when that click occurs, the individual is experiencing regurgitation. They can also damage their endocardium and as a result lead to endocarditis. When you have endocarditis, once again, the valves become inflamed, making them sticky, leading to the production of these tiny little thrombi, which could embolize.